Dr. Yukut will now address the difficult issue of amyloidosis. And echocardiography plays a key role to assess the morphological abnormalities in this disease, but also to assess systolic as well as diastolic dysfunction that can be encountered. Finally, she will insist on the impact of new technologies to detect subclinical dysfunction.
Amyloidosis is a group of disease which is characterized by the extracellular deposition of amyloid proteins. It can involve several organs like the heart, the liver, or other organs like the kidney. But cardiac involvement, the one that interests us today, is the one that is also associated to the worst prognosis. I will show you the case of a 53-year-old patient who came to our clinic for a cardiac assessment. You can see from the very first images from his parasternal long axis that in this patient we have a significant LV hypertrophy of a concentric type, but with the main involvement of his septum, with a ventricle that is of normal dimensions. And we can check this by measuring at end diastole, first the dimensions of his interventricular septum, which is 20 millimeters, and then the cavity, which is of normal dimensions, 48 millimeters, with a 13 millimeters posterior wall from this side. You can also look at the fact that his interventricular septal structure is of a particular type. It is inhomogeneous and also it is quite sparkling. And when you change your image to a short axis view at the level of the papillary muscles just below the mitral valve, you can observe again that the hypertrophy involving mainly the interventricular septum is, however, of concentric type, and that the radial function of this ventricle looks as being preserved. As a characteristic of amyloidosis, there is the voltage to mass ratio, which is low, meaning that even if the LV walls are thick due to infiltration by amyloid, as you see in these echocardiographic images, the ECG shows a low voltage of the QRS complex. And this is typical for infiltrative diseases like amyloidosis. You can also guess, both in this image and in the previous parasternal long axis image, that there is a small pericardial effusion that is also a typical feature of cardiac amyloidosis. Turning then to the apical view, thank you, of the patient, we can see again the characteristic LV hypertrophy, but also other findings that are associated to amyloidosis. First of all, there is a degree of biatrial enlargement. And of course, we will want to assess the left atrial volume as a measure of the left atrial dimensions. The best we have from four-chamber view using the length area method. And we will have a volume of 73 milliliters, which indexed over body surface area gets us 45 millimeters per meter square. Also, looking at this image, we can see there is an infiltration of the interatrial septum, which is a characteristic finding in cardiac amyloidosis. Also, visually, the atrioventricular valves, mainly here the mitral valves, appear a bit thickened, and also with colored Doppler there is a small atrioventricular mitral regurgitation, which can be more severe with more severe forms of diseases which are leading to a form of restrictive cardiomyopathy. Going back to the 2D image, we can observe that the LV ejection fraction is visually preserved, and this can be checked by the biplane Simpson method. And indeed, while this patient had a normal left ventricular ejection fraction, while visually and based on the biplane Simpson method, the LV ejection fraction appears as normal, we should look at other parameters to be sure if there is any dysfunction of the left ventricle. And in order to do that, we will assess the myocardial velocities of the mitral annulus at the septal side. And here we will first measure the systolic peak velocity, which in this patient is 5 centimeters per second, which is clearly an abnormal velocity showing a subclinical longitudinal dysfunction of the left ventricle. Moreover, if we use all his apical views, looking at his 4-chamber view, 2-chamber view, and 3-chamber view, we can derive, using automated function imaging, the bull's eye of the map of his myocardial deformation, which shows us very elegantly that there is a significantly decreased global left ventricular strain of -12% only, but with a very specific map with apical preservation of strain deformation, which was recently proven to be highly sensitive and specific for cardiac amyloidosis when needing to differentiate it from control patients, while all the other segments have abnormal longitudinal deformation in systole. Having said that, we should also look, of course, at the diastolic function of this patient. And when we go back to the pulse wave images that I showed before of the mitral annulus, we can also measure his E' wave, which is severely decreased at 2 centimeters per second, showing a severe diastolic dysfunction of the left ventricle. Moreover, when we go to the mitral valve inflow, we can see that while there is a pseudo-normal pattern at this side, the ratio of E over E' is very high, of 24, showing that there is a sign of highly increased filling pressures of the left ventricle and confirming the severity of the diastolic dysfunction of this ventricle. Of course, this is a caricatural case of cardiac amyloidosis, the one that we see in end stage of the disease. One of the challenges of cardiologists in team with hematologists when they have to diagnose the cardiac involvement in amyloidosis is to find the disease in very early stages. And several studies have shown that before systolic by conventional parameters or diastolic dysfunction occurs, the first parameter that can show early LV involvement in amyloidosis is still myocardial deformation using tissue Doppler imaging or speckle tracking. Another question in these kind of patients is if the right ventricle is also involved. When we go to the subcostal view of this patient, we can see that the free wall of the right ventricle is thick, and if we want to measure the thickness from this view, we can zoom on this image, and then we will see that actually the thickness is around 8 millimeters, which is indeed higher than the upper normal limit of 5 millimeters. Moreover, if we are questioning the function of the right ventricle, apart from the parameters that are conventionally used for that, like TAPSE, which is 18 millimeters, so in the normal range, or the S' of the right ventricle, which is 13, so in the normal range, we could, however, find that there was a level of subclinical dysfunction at the right ventricular wall as well, with a global strain around -13%, mainly due to a dysfunction of the interventricular septum here, but also with low abnormal values of the strain of the right ventricular free wall. It is considered that the involvement of the right ventricle as well as the left ventricle encompass an even worse prognosis than just left ventricular involvement. All these findings need to be always interpreted in a larger clinical and paraclinical setting. Of course, you need to judge your findings based on their association with the clinical picture, the laboratory workup, and the ECG findings, as said before, as amyloidosis is a systemic disease and the cardiac involvement is only part of this puzzle.
So you have understood that echocardiography is very important to assess the prognosis of the patient and to detect late stage of the disease, but also to detect subclinical dysfunction and early stage of the disease when treatment is still possible. Nevertheless, it's very important to keep in mind that we have to integrate ECG findings, biological findings, and also clinical findings, since this disease is a systemic disease.